immediately. Well, good afternoon. I think this is the fourth or fifth talk in the masterclass series with CIPLA as academic partner on different respiratory subjects, I think. Last time we had discussed inhalation therapy as a kind of comprehensive subject, you see. And so this is the second part of the inhalation therapy as the kind of nebulization, because there are a lot of issues regarding nebulization, and as you all know, this is becoming more and more popular, you see. So I shall discuss briefly the general indications, principles, and the basic kind of physics you see about nebulization, and subsequently Aditya will discuss the indications about so as you all know that the pulmonary delivery of drugs, you see, is one of the you can say greatest discovery during the last 50 years or 100 years, you can say, because it has been shown in multiple studies that it almost parallels the intravenous injections as far as the drug effect is concerned. In fact, so that is the greatest advantage of direct inhalation therapy or pulmonary delivery. So you can see here, in fact, this second shows that the peak effect with inhalation is even better, you see, than the nebulization. You see the violet circles you can see here. Otherwise, the pink are shown the kind of peak levels of the peak levels, and then of course the sustained levels over time of the inhalation route, you see. So that is the importance of inhalation route, that the effect is almost simultaneously, almost as with the intravenous injections, you see. And there have been several studies which compare that the route of delivery for airway diseases as such, and you can again see the same thing that the forest plot, you see, all those studies show that both are equal, you see. There is no favor for intravenous or inhaled therapy with either, in fact. So all the mean levels and all the parameters with both these routes are similar, you see. So obviously inhaled route is a preferred mode, especially for the airway diseases, because it is easy, safe, faster onset of action, more effective than the parenteral routes in some aspects, you see. The other thing is what are the factors which affect the pulmonary drug delivery or inhalation, because a lot of factors are important. Most important is the particle size, the flow, inspiratory effort of the patient, and the particle deposition in the respiratory tract. And then there are device related factors, which kind of device has been used, the nature of the device, ease of use, the patient related factors, because that is a very important issue which we will discuss in the subsequent slides. Technique of use of the device, the pattern of breathing, the geometry of the airways, and the severity of the disease. So all these factors affect the inhalation efficacy of the drug. Besides the size of the particle, another important issue is the airway geometry, because that is very important for particle deposition, because you know that the airways, they divide, they divide, subdivide, and go on doing like this. So obviously whenever there is a flow of any kind of vapor, aerosol or air, so whenever it kind of meets a division or a bend, you see, there would be deposition of the particles here. So at all the bends and divisions, the aerosol, as it moves into smaller and smaller airways at bifurcations, so particles keep on getting deposited, you see. So that obviously that would affect the effect of the drug uh, where they are deposited, you see, and the smaller the particle size, the distant the deposition in the lung, you see. That is what is shown here, that generally the particle size, if it is more than 5 micron, it gets deposited in the mouth and kind of esophageal region, and no clinical effect will be seen here, you see. But the smaller particles of 1 to 5 microns, they get deposited in the upper and central airways, and they will have clinical effect. And the smaller particles less than 1 micron, they go to the peripheral airways. So the smaller the size, the distant the deposition in the lung. I think that is the important issue as far as the inhalation therapy is concerned. I talked about this slide last time, that the type of inhalers, the inhaler device classification, the meter dose inhaler, the dry powder inhalers, which you all know. There are plenty of these types of inhalers, and then there are nebulizers. Nebulizers, we have kept it as a separate talk, because the nebulization is an important component of inhalation therapy, and it is becoming more and more important. In fact, there were reports that during the COVID times, there were several kind of times increase in the sale of nebulizers in this country, you see. People were just buying it without any indication, so they were using it indiscriminately as well, you see. So that's how the nebulizers have become even more popular following this epidemic. Now, comparing the inhalation in general and the nebulization, the inhalation, of course, delivers high concentrations directly to the disease site. There is a rapid clinical response. The risks of systemic side effects, for example, with corticosteroids, they are very minimum. It bypasses the barriers to the therapeutic efficacy. There is poor gastrointestinal absorption and first pass metabolism in the liver. And I have shown earlier that they achieve a similar or superior therapeutic effect at a fraction of the systemic dose, you see. So that is the beauty of inhalation therapy, that even with this very small dose, micro dose, the effects are as similar as with intravenous routes. The nebulization is almost similar to inhalation. Here the drug delivery is with an air pump, which is driven by power used, electric or other ultrasonic power, you see. It is used to convert the liquid drug into the aerosol. See, that is a kind of the principle of nebulization. It was first invented in France to atomize the liquid medication, and then of course, and he used the bicycle pump, which was operated like a pump, and sorry. And then of course the Venturi pump was used, and subsequently the modern inhalers came up, you see. What is the principle of nebulization? I think this is the very important, the Bernoulli principle, which is also used for aeroplanes and so many other things, you see. And it is basically a very simple thing, that whenever there is any air or gas is passed through a narrow orifice, a kind of nozzle, then it expands, you see, and there is a sublateral kind of the lateral subatmospheric pressure created around. For example, here that is the air or gas which is flown through this nozzle, and it basically expands to become a steam, and then there is a subatmospheric pressure around here, and the liquid uh, which is placed here in the canister, it just evaporates, you see, it comes. And so these are the essential components of a nebulizer, and then there is a buffer uh, placed here on which the larger sized particles get deposited, so that only the fine particles are finally inhaled in the kind of at the outlet of the nebulization. See. All of all of you are aware of this steam inhalation, and a lot of patients put this question that can I use steam? Actually, the nebulization is almost similar to steam in several ways, although it is not the same thing. Steam, of course, gives some comfort. It is a soothing kind of comfort. It provides moisture to the dry mucous membrane in the nose and throat. It helps to loosen the secretions. It encourages cough, may reduce bacterial infection in the nasal passages. But there are problems with steam, that it is excess hot vapor or steam. Sometimes it can cause burns, local damage to the nose and throat, and there is greater risk in children, you see. Most importantly is that most of the steam particles, they remain deposited in the throat, you see, or in the mouth. They are not really inhaled. Most of the particles of steam do not go to the bronchi, you see. On the other hand, nebulization, it breaks particles up further to make a finer and deeper reach. I think that is the most important issue. As I said earlier, that smaller sized particles go deeper and deeper, you see. Now, how do you compare the nebulizer with a meter dose inhaler? That I think there are several studies which show that the meter dose inhalers, the effect is almost similar to that of a nebulizer, especially when the MDI is used with a spacer. The advantages are that MDI, the inhaler, is a smaller in size, it requires no power source, you can keep it in your pocket, and it delivers the medicine very quickly than a nebulizer, and it is as effective as a nebulizer. I think that is very important. But there are some problems, that it requires coordination. It is difficult to administer in the elderly, small children, patients with disabilities, arthritis, dexterity issues, and so on. We'll come to some of these issues repeatedly in today's talk, you see, because these are the important issues. And especially when the patient is more sick, acute attack in asthma or COPD, it is difficult. On the other hand, nebulizer, it is good for all age groups, small children, elderly, sick patients, as well as the patients with disabilities, serious diseases, very low operational cost, etc. There are some disadvantages, that it creates noise. People find it difficult. It is less portable, greater weight. You cannot carry it routinely to your office, etc. Although smaller and smaller sized nebulizers, which are noiseless, are being discovered these days. Lot of the dose is much higher with the nebulizer, see, compared to the meter dose inhaler, and there's a lot of wastage, and a lot of it gets deposited in the mouth. Now there are many types of nebulizers, like the pneumatic nebulizer are the most popular and commonly used, the jet nebulizers, which are connected by tubing to a supply of compressed gas, most commonly used in the hospitals with a big oxygen tank. You just connect it, and kind of the oxygen is flown through the nozzle of the nebulizer, and it converts kind of liquid into the aerosols. Then there are mechanical. The soft mist nebulizers, they are not yet available freely in this country, where they say there is very low velocity of the mist, and it is like a conventional meter dose inhaler. It is a hand-driven nebulizer. For the time being, it is costly, quite costly, but I am sure that with time it will become cheaper. They are almost, uh, although you cannot use any drug, with nebulizer you can use many drugs, you see. Uh, Here only the kind of the marketed drug will be available with this soft mist, like in MDIs, you see. So then we have electrical and ultrasonic nebulizers, which are commonly used in the hospitals. These, of course, are even useful at home. Although these differences are disappearing because smaller kind of devices are being available with ultrasonic nebulizers as well. You see. Here there is a kind of piezoelectric element, which is in fact which the vibrating element, it converts liquid reservoir into the high frequency, with a high frequency vibration it converts liquid into the vapor mist. So importantly is that the jet nebulizers, of course, the most frequent nebulizers, and these are relatively more kind of you can say, when you require for a larger number of patients a heavy nebulization, etc., these can be used. You see. So the indications, I'll just briefly talk. The first line treatment for severe attacks of airway diseases like asthma, COPD, and then bronchitis, bronchiolitis, and emphysema, etc. And sometimes it is also used for persistent respiratory symptoms like cough, wheeze, and tightness of the chest. Also, the nebulization can be done for many other drugs, you see, which like antibiotics. They're most nowadays quite a few antibiotics are available as to be nebulized. For example, tobramycin is one important one, and then even colistin is given as aerosolized antibiotic. Then amikacin might also be available soon. So a lot of drugs can be given as aerosolized drugs. Chronic lung infection like Pseudomonas aeruginosa and patients with cystic fibrosis or even with non-cystic fibrosis bronchiectasis, you can give not only the antibiotics, you can also give the mucolytic agents. You see, that also is another important. Sometimes even saline or hypertonic saline can be given for mucolysis as well as for encouraging cough. Inhaled pentamidine was given for pneumocystis cerevisiae pneumonia, especially in patients with HIV, and also for treatment of hyperkalemia in renal failure. You can use solvitamol and so on. I talked about the handheld nebulizer earlier, or the soft mist nebulizer. They are liquid-based inhalers which produces slow-moving aerosol. It is easy to take, you just like a nebulizer, so no patient coordination is required. It's a fine mist, more slowly, it lasts longer, you see. For delivering treatments for short-term care, acute effects. So even with poor inhaler technique, sometimes even children can be taught, you see, with small children, it is easier to administer. It is suitable for many biological formulations as well, and it is a greater sustainable, can be reused as well. I think maybe in near future multiple inhalers would be, the soft mist inhalers will be available. And just briefly, what are the inhalational drugs or nebulizable drugs? You see, inhalers, most of these drugs are available. Nebulizers, of course, the same machine is used for nebulization of different drugs. Bronchodilators, both short-acting beta agonist, long-acting beta agonist, short-acting muscarinic agents, anti-muscarinic agents, SABA, LAMA, and corticosteroids, of course, is an important one, and importantly the combinations. In nebulization also you can give combinations, you see. Here though ampoules available are different, there are no combined ampoules available, like combined inhalers are available, of course. Here you can use different ampoules and combine together in the nebulizer, you see. And as I have said, the antibiotics, mucolytics, and hypertonic saline, etc., that can also be used. I think these are the, just kind of repetition. You can see that the factors associated with non-compliance in asthma and COPD, and there are many difficulties with both medication use, like difficulties of inhalers, complicated regimens, fears about actual side effects and cost, etc. And then of course the patient and the physicians also have own misunderstandings, and sometimes underestimation of severity, and other factors, you see, which are important in their use or misuse. So in all these places you can consider nebulization because of its ease of use and technique, effective and reliable drug delivery. It fosters patient confidence, you see, that drug is reaching the lungs. Patients are more confident than the doctors that the nebulization is doing its job. That's why I told earlier that during COVID era there was a marked increase without prescription, you see, all the patients, people were using different nebulization. And these days many patients, they come that they would prefer nebulization, and they report positive effect immediately, symptom relief is there. And importantly here, the disease, the use is not limited by disease severity. So all these factors are important whenever we talk of nebulization. So the jet nebulizer use is easy, just you open the vial and transfer the medicine. So patient find it very useful, and then connect the nebulizer reservoir to the mouthpiece and to the compressor, and of course insert the mouthpiece and turn on the compressor. Patient just breathe as calmly and deeply until no more mist is formed. So basically it is easy to use, you see. Jet nebulizer also I have said earlier, so it just explained in the that there is the air or gas is flown through the nozzle, it breaks the drug or the liquid into finer particles, and when patient inhales, the expiratory valve closes, and on expiration the expiratory valve opens. So the nebulization delivers the effective dose. This is a cumulative dose study. There are multiple inhalations from MDIs are required to achieve the same amount of bronchodilation as from larger nebulized dose, you see. That is the important effect, that it is not necessary to use nebulization if you can use inhalers. But with the inhalers or MDI, one has to use a kind of spacer, you see, and multiple doses are required to produce the same effect. And this study compares, this is an important study which had compared and found almost similar effects with both the things, you see. So nebulization reduces technical errors of, I think this is just repetition of what one has talked earlier, that most important steps, you see, these are the two important steps where errors are common with the patients, and many times they would just place the inhaler mouthpiece between the lips and keep the tongue obstructing the mouthpiece, you see. So coordination becomes problem, inhalation becomes problem, and the other step, of course, is also they trigger the inhaler while breathing in deeply and slowly. This should be about 30 liters per minute. So larger inspiratory flow is required with the uh, with the inhalers. Same is true for DPIs, the dry powder inhalers. The commonly errors are associated with drug release, etc. And this is, you can see here from study that although the MDIs and DPIs are the first choice of delivering aerosol, but almost 46% of patients and 17% of those using DPI rated their device difficult to use. See, they find it easy with the nebulization. 50% of DPI's users were unsure as to whether they received any clinical benefit. Even these days when patients come, many of them feel they don't even feel that something has gone in, I think. 'Cause on the other hand, the very fine particle inhalers, which are otherwise better, they are generally not found to be satisfactory by the patient because they don't feel anything kind of sticking to their throat, or at least feeling in the throat, you see. And especially the spacer device is, of course, the most important. So I think with the, I think I have talked about most of the advantages of nebulization and basic principle. Now specific diseases, COPD and asthma, Aditya will talk.
So thank you, and we'll be focusing on two main diseases in which these nebulized devices are used, and what are the indications for the usage, and what is the evidence for the usage. So the most common device, the maximum usage of nebulizers is for acute disorders like acute attacks of asthma or acute attacks of COPD. And nebulizers form the main delivery system for most emergency departments and hospitals all over the world, either in the developing or in the developed world. And they are widely used because of their convenience, and less patient education, cooperation is required. Anyways, patients who are extremely breathless will find it difficult to take either a meter dose inhaler or a dry powder inhaler. So the inhaler technique problems are overcome and do not become an issue in the emergency setting. So this is just maybe I can ask a question. So which is the first drug of choice in acute severe asthma? Nebulized steroids, injectable theophylline, nebulized salbutamol, or injectable dexamethasone? So, pardon? Okay. And your? Any other guesses? So yeah, so it is nebulized salbutamol because this is a beta-2 agonist and which will act almost instantaneously, while the injectable dexamethasone will take few hours to act. So it is important to remember that the injectable steroids, even if they are given intravenously, they will take significant amount of time to act, while the nebulized medicine will act almost immediately. So either a salbutamol, or you can even add on a ipratropium, which are the short-acting and immediate-acting sort of beta-2 agonist and the muscarinic agonist. Yeah. So the dose is around 2.5 to 5 milligram every 20 minutes for 1 hour, or they can be given as maybe you can give 3 respiles together also, and give continuous nebulization for half an hour also. So these are different protocols which can be used. But so if this protocol is used, then initially give it every 20 minutes, or for 20 minutes for 1 hour, then every 1 to 4 hours as needed. And meantime, you can add on the other medicines like steroids or antibiotics or whatever you want to use. And in children, half this dose can be used. And you can also use levosalbutamol, which is an isomer of salbutamol but causes less tachycardia. And in addition, if it has not been approved, you can if the disease is not being controlled, we can add a short-acting muscarinic agonist, that is the ipratropium, and this is the dose which can be again given every 4 to 6 hours. And these can also be used in combination, and we all know that the combination SAMA and SABA are available in our country. So this is just a case, a GC, 72 years old construction worker, had dyspnea over 4 years, and on and off bouts of cough and phlegm, had winter exacerbations, unable to do anything at all, and was a chronic smoker, 30 pack years of smoking, and tried to use both metered-dose inhalers and dry powder inhalers. So, and was not able to take the medicines because he had some tremors. And the physical examination showed a decreased breath sounds bilaterally, no wheezing, and he had a MMRC of 3, 6-minute walk distance was reduced. FEV1 was low, it was 49% predicted, board score was 2. So what are the treatment alternatives? So should we continue to try with a different DPI device? Use a metered-dose inhaler with spacers only? Consider nebulized therapy? Or don't treat his disease, as it is not too bad? Yeah, so any of these things can be tried actually, but yeah, but so maybe in this patient, some people would respond to maybe he's not taking a space or anything, but I think D option is totally wrong, definitely. So nebulized therapy is one thing, home nebulization which can be given, or especially in these kind of patients. So these are all the different kind of devices that are available, and we've already mentioned the different types of nebulizers. Basically, there are 3 types of devices: dry powder inhalers, metered-dose inhalers, and nebulizers. Age is a major factor that determines the correct use of inhaler devices. Then, because of the decrease in the muscle strength, memory problems, and loss of coordination. So this is something which is not considered most of the times when prescribing either a metered-dose inhaler or a dry powder inhaler. Especially, it is the most common practice to give dry powder inhalers to elderly patients. But because of all these issues, they are slightly unable to take it. And you can see that mishandling of inhaler devices based on the patient age. This is a graph showing the same thing. So as the patient's age increases, you can see that the white graphs are showing the patients who are sort of aged, and they have more difficulty in using all types of inhalers. So while the younger patients, they have less difficulty in using the inhalers. So this is because of the age-related issues. So the older the patients, significantly poorer device technique than in younger adults. And this study showed that there was inadequate technique was high at the baseline, and in one study, at least in one sort of instance, almost 81% errors, and clear statistic improvement was observed with active education versus passive. So instead of just showing them sort of pamphlets or giving them books or showing them a video, active education, trying to actively educate, checking their technique in front of you or in front of a sort of educator is much better as compared to just passively telling them you have to do this and then letting them go. So also another thing is, this was, I'm talking about the first visit. So patients who come for revisits, so the technique tends to deteriorate with time. So every visit or at frequent visits, the inhaler technique has to be retaught to patients. And among older COPD patients, of course, generally education is neglected, either because of physician factors or because of patient factors. Generally, patients are older and they don't want to listen to doctors also, and they'll say that, yes, you have taught me last time, I know this already, I've been taking for so many years, all these things are there. So this is one of the reasons of poor inhaler techniques. And as already mentioned, that written information is insufficient to achieve improved technique on its own. So also because of old age, the acquisition and retention of the technique is sort of poor or reduced because of cognitive defects. So that was age, one factor in the inhalation technique, and another factor is the peak inspiratory flow rate. So the elderly patients' muscle weakness and air trapping may decrease the ability to generate the minimum required inspiratory flow rate. And if you can see this X-ray, you can see there are a lot of bullae here. There is a lot of air trapping. So this is the normal lung, and you can see the rest of the lung is black. The whole of the chest is hyperinflated. There is a lot of air trapping, and there are a lot of bullae here. So this patient will be, it will be very difficult for a patient to generate inspiratory flow and take a adequate inhaled therapy, that is either the MDIs or the DPIs. Yeah, so irrespective of the presence of COPD, elderly patients might find it difficult to generate a inspiratory flow. And these are different types of dry powder inhaler devices. You can see that there are there are very high inspiratory flow rates for some of these devices, and some patients are not able to generate up to 30 liters per minute of inspiratory flow. So that is the minimum acceptable. So no device is there in which a less than 30 liter per minute inspiratory flow can generate a good drug delivery to the lungs. So some patients are not able to do that, or a lot of patients are actually not able to do that. So what are the consequences of the poor technique? So overuse of medication, wasted medication, lung deposition significantly reduced, suboptimal therapy. So answer of course is all of the above. This adherence is significantly but if the patient is able to take the therapy, then the adherence is associated with a reduced risk of death and admission to the hospitals due to exacerbations in COPD. So we started off with asthma, now we're talking about COPD, and you can see that this was a 3-year trial, and you can see the difference in the mortality in patients. These were the patients who were not taking or not properly taking the inhaled therapies, and this was the patients who were taking the inhaled medicines properly and were adherent to that. And you can see that there is a massive difference between these two groups of patients at 3 years of age, at 3 years. So it is very important to sort of stick to the inhalers, or it is very important to deliver the medicine to the patient any which way we can. So it comes to the question that if patients are not able to use the inhaled therapies, the dry powder and meter dose inhalers, are nebulized devices an appropriate alternative for use for home nebulization? Yes. So how to translate the benefits of these new medicines or devices into health gain for individuals? So normally 20 to 30% of prescribed medicines are not taken as recommended by the doctor. And adherence is defined as the extent to which a patient's behavior matches the agreed recommendations from the prescriber. So what is the efficacy and safety of nebulization for COPD? Patients using combined, some trials are showing that the patients using combined nebulizer therapies in the morning and night with midday use of inhaler device had the most statistically significant improvement in the quality of life indices. And so this was a concomitant regimen which they used some medicine as nebulizer, some as inhaler, and this showed additional symptom relief offered by a nebulizer with the convenience of an inhaler. And you can see that formoterol was delivered by nebulizer. It was as effective as that delivered by a dry powder inhaler. So this was the yellow one was the nebulized therapy, and this was the dry powder therapy. So at day 1 and week 12. So you can see that these are parallel. Graphs are parallel. So it was nebulized therapy is as effective as DPI, but also DPI is as effective as nebulizer if taken properly. So there is as such no difference. It is only when patients are unable to take the other devices, that is the meter dose and DPIs, that we should be thinking about nebulized therapy. And there is a similar sort of result with the R-formoterol nebulized solution versus the salmeterol MDI. So the FEV1 mean changes in the morning pre-dose FEV1 was almost similar. And this was a study showing the formoterol nebulization plus tiotropium. So you can see that this is not visible, but these are the graphs showing I think formoterol, and this is without. So and this graph is showing at week 6. This is showing at day 1. So this graph is showing the improvement in the improvement with both nebulization plus tiotropium, and this is showing placebo. So if on the solid graph is for day 1, while the dotted graph is for week 6. So you can see that as compared to placebo, there was a marked difference when this regimen was used, and there was also a significant improvement in the SGRQ, or the score versus placebo. There was a significant improvement in the dyspnea and health status as compared to the placebo. And the rescue use of salbutamol or albuterol reduced over the 12 weeks when this combination was being used. Risk of exacerbations reduces in COPD with use of nebulized solutions like formoterol, and the overall risk of side effects is is there, but it is not that significant. And you can see that in very severe COPD, formoterol budesonide nebulization versus PMDI, that is the meter dose inhaler, the pre-bronchodilator FEV1 is significantly different in these patients as compared to the in the nebulized treatment as compared to the meter dose inhaler therapy. So from the patient's point of view, what are the most positive effects of chronic nebulization therapy? So enables one to breathe easier, is quick, has quick relief and fast acting, able to do more activities and live life more sort of normally. And nebulization survey, this was a survey data which supported that patients were satisfied with nebulization, and most patients responded very positively to nebulized therapy. And the majority of caregivers also recognized that the benefits of nebulization was there. So what are the clinical scenarios in which maintenance nebulization is preferred in patients with COPD? So first is of course cognitive impairment that precludes the effective use of handheld inhalers. So patients are bed bound or they are not mentally clear. There is impaired manual dexterity due to arthritis. So you can see patients with rheumatoid arthritis who are unable to sort of bend their hands or fold their hands. Neurological alterations or stroke patients who are unable to use the inhalers to generate that amount of inspiratory flow rate. Patients who have severe pain or muscle weakness due to neuromuscular disease. Or there is a patient preference for nebulizers. So, but we'll still say that use of either MDIs or DPIs is still preferred as a maintenance therapy in both patients with COPD and asthma. But once you are shifting a patient on to nebulization, there should be a very clear-cut indication, at least in your mind, why you are doing this or why we are doing this. It should not be an upfront therapy because there are significant costs and maybe side effects also involved with that. But still it is a very viable treatment option right now. So other indications are failure to comply with the use of inhalers, and when sometimes multiple agents need to be co-administered, there is insufficient inspiratory capacity to use especially the dry powder inhalers, and there is unable to use the PMDIs and the DPIs in an optimal manner despite adequate training or spending enough time with the patient, but they are unable to use that thing. So in stable COPD patients, if patients with stable COPD experience symptomatic benefit with nebulizers, that is greater symptomatic benefits with nebulizers, then withholding nebulized therapy from these patients might be denying them the ability to better control their symptoms, reduce acute exacerbations, and enhance their quality of life. So this is important, that if patients are unable to use the inhalers or there are significant benefits with nebulizers, then we should be giving them the nebulized treatments. So of course this is from a article which they have mentioned some guidelines on how to use the nebulizers, but there is no point in denying nebulizers to anybody, but they should not be used upfront or indiscriminately. I think that is also very important. Nebulized therapy is also sort of help in clearing mucus, and airway mucus is secreted by goblet cells. It is part of the lungs' native immune system, traps particulates, microorganisms, but excessive production can sort of cause extreme cough, and this is very common in patients with chronic bronchitis or COPD. Because of the changes in the rheological properties of the mucus, there is deficiency in clearing the mucus, ineffective cough reflex or mechanisms. So this all leads to infection, inflammation, airway obstruction, and parenchymal damage. So nebulizers are also sort of helpful in improving these kind of symptoms. So I think we can just skip this part. So again, to reiterate, conditions where nebulizers must be used are, so one is where drugs can be delivered only by the nebulized route. Second, acute exacerbations of asthma or COPD requiring hospitalization, altered mental status, cognitive decline, or confused state. In fact, in the second indication, some of these patients who don't want hospitalization, you can give short course nebulized therapy and maybe avoid the need for hospitalization. But this has to be used very carefully in patients who can give feedback and come back to you and tell us if any problem is there. So if the patient is from a far-flung area or is not that sort of alert to changes in his or her own status, then this for nebulized therapy for acute exacerbation should not be given. But patients who have good support bases or who are cognizant of that any sort of complication might occur, so these are the patients in which home nebulized therapy for acute exacerbations can be used. Patients who are inadequately controlled on the DPIs or MDIs and who need high doses of the medicines can be given nebulizers. Lack of coordination while using the MDI despite best efforts to train them. Maybe there are some visual factors then which limit the ability to use DPIs and MDIs. Patients who have blindness, macular degeneration, cataracts, glaucoma. Dexterity issues such as Parkinsonism or stroke, hand arthritis, non-cystic fibrosis, bronchiectasis. And these patients require inhaled antibiotics or courses of antibiotics. Bronchiolitis sometimes, cystic fibrosis, and pulmonary arterial hypertension requiring inhaled therapy. So drugs, there are some drugs which can be given only by the nebulized route as compared to the inhaled therapy. So antibiotics, tobramycin, colistin, amikacin, fluoroquinolones, pentamidine, these are not available as inhalers. Mucolytics are not available as inhalers, so Dornase alpha, N-acetylcysteine, hypertonic saline. Some of these medicines are also available as inhalers. These are the bronchodilators, salbutamol, levosalbutamol. So these are common, and you can see these lot of combinations also in the nebulized form. So you can get nebulized glycopyrronium also is available nowadays. Lot of steroids are available. Commonly only two steroids are available for nebulized, either budesonide or fluticasone. And others like interferon beta, these are sort of rare indications, but can have been used from time to time. And this is a NEB score card for indications in primary care. I think you can go about this later. And in summary, nebulization is the most effective and convenient form of inhalation therapy for acute asthma, exacerbation of COPD, and other conditions where MDIs and DPI use is not possible. Nebulization is the only method to administer certain drugs for which inhalers are not available. Domiciliary nebulization is indicated as maintenance therapy of COPD and even asthma for certain categories of patients, which we have already discussed. And a scoring method is available to decide who to give nebulized treatment for use in primary care settings with limited resources. So, thank you. Any questions or anything? Or
So when it comes to the interstitial lung disease, along with any COPD or allergic asthmatic, do you think the nebulization will work better or the inhaled therapy will be as good?
I think first of all we have to be clear that interstitial lung disease itself does not require any form of inhalational therapy. If there is coexistent COPD or asthma, if the patient is an ex-smoker and has those kind of symptoms, these are the only sort of indications most of the times. In these patients, if the patient is quite breathless, then and has difficulty in holding his or her breath, of course, because in severe ILDs, patients would not be able to do that. Or sometimes there is combined pulmonary fibrosis with emphysema, which is an entity. So there these treatments can be used, but in patients who are unable to hold their breath or are breathless, they will find it difficult to use, especially the dry powder inhaler. So in those cases, the meter dose inhaler with spacer can be given. And if they are unable to use this, then of course the nebulized therapy can be done. But primarily it is not the sort of treatment for ILDs. So they are mainly treated by either immunosuppressant medicines or by the antifibrotics. So is any other question? You cannot use budesonide in ultrasound inhalers, or you can use. So it all depends on the particle size. So ultrasound inhalers are generally meant for finer particles. So because that Yeah, so sometimes so sometimes it's not there, but I think it is, you can use budesonide for with the ultrasound inhalers. So ultrasound inhalers generally provide slower nebulization, but they provide deeper penetration into the lungs. Especially useful for nebulizing patients before preparing them for bronchoscopies, or for patients who are sort of on the ventilator, those kind of patients. But of course, they can be used in the general population also.
Steroid budesonide or other nebulization is should not be done routinely. I mean, if it is sometime, because steroid, a lot of deposition occurs in the mouth, problems of candidiasis, especially for long term, it should be avoided. But of course, in emergency situations, acute attacks, you can certainly do that. But for maintenance therapy, generally there is a caution with whether it is budesonide or other steroids as well. ठीक है, उधर तो नहीं कोई क्वेश्चन कोई? Okay, there. I think, thank you very much. There is nothing more. Thank you.